Okay.
Yeah, so good evening, ladies and gentlemen. Good morning, good afternoon, good evening, wherever you are. Thank you very much for joining us in this special webinar. And tonight with our special guest, Prof. Nandu Thalange, in very interesting topic about treatment of precocious puberty. Let me just remind you that for this special webinar, we got about 390 registrants from different countries, from Indonesia in the east to Mexico and United States in the west. And the farthest in the north, we've got Ireland and the UK, and the farthest south is Tanzania. So we got colleagues from everywhere. And we got a very special speaker tonight, as internationally recognized leader in pediatric endocrinology, Professor Nandu Thalange. He brings decades of experience, groundbreaking research, and a deep commitment to improving children's health. From leading global trials that transformed diabetes care to launching the UAE's first pediatric endocrine fellowship, his impact spans continents. So it's your opportunity to not just learn from him tonight about the precocious puberty, but to ask him questions related to how to enhance your experience in pediatric endocrinology. So use the opportunity. Use the Q&A box for your questions, and we'll try to accommodate that within the hour. Prof. Nando, the floor is yours.
Thank you very much, Hussein, for the very kind introduction. So let me see, how do I move the slides? There we are. So disclosures, no disclosures relevant to this talk. And I'm going to tell you about four very different cases, which I hope illuminate important points about the investigation, management, treatment of precocious puberty. So first of all, let's talk about Fatima. Now, Fatima was not actually my patient. I was consulted about Fatima from overseas by a colleague, and she is 7 3/4 years old, with very tall stature and breast development. It was difficult to tell exactly, according to my correspondent, because she was very obese, as you can see, plus 3.2 standard deviations. And that is one of the challenges we have, that obesity causes lipomastia, where you get the apparent breast development, but you're not sure it's glandular breast tissue. And so you have to feel, you have to actually palpate the breast to determine this. Or you can do an ultrasound, which is another way of doing it. Her bone age was plus 2.8 standard deviations based on manual reading of bone age. And her height prediction was actually rather good, 168.2 centimeters. There was a pelvic ultrasound report, but unfortunately, I can really have little confidence in it, because unless the report contains details of the ovarian volumes or uterine size, that's really not good. And a lot of pelvic ultrasounds are reported by adult radiologists, and they're not giving those key bits of information which you need to really interpret this situation. So, if the ovarian volume is large for age, then that really is going along with precocious puberty. If the uterine size is enlarging, that will also do the same. Although I have to say that usually in early puberty, you're not going to see much of a change in uterine size. If it's just at breast stage 2, there's not much estrogen exposure, the uterus hasn't had time to develop, but you might start to see ovarian enlargement. So it's important to have a good a radiologist you can trust who's doing this test. So now I've got a couple of questions for you in the presentation. So now, first of all, the question that my colleague was specifically asking me was, should we do a GnRH test? He wanted to know if this would help in the diagnosis of precocious puberty. And this is my advice to him, and you can tell me whether you agree or not in a moment. So, in my opinion, this is almost always an unnecessary test. I think it's very important if you think someone has GnRH deficiency. Let's say you're treating a child with, craniopharyngioma, and you're not sure if there's any gonadotrophins present, then it's a brilliant test in a pubertal age child without signs of puberty to tell you if you need to induce puberty or whether you can wait a little. And I think if you have a child who's gone into central precocious puberty, but it started off as peripheral or gonadotrophin independent precocious puberty, then it can tell you that. But I think it's almost always unnecessary in straightforward central precocious puberty, and even in more complex central precocious puberty for that matter. So, first question, should we do a GnRH test? So I see there are 61 participants, so please, I want to see 61 responses. I have to say you're an enthusiastic lot. We're already up to 35 after about 15 seconds, which is pretty good. So I think you're slacking now. I think the non-respondents are officially sitting on the fence, but we have a 50-50 split between those who think we should do a GnRH test and those who don't think it is necessary. So should we end the poll, Hussein, or should we
Yeah, I
wait a
ended the
moment
poll and I
longer?
shared the results with everyone.
Okay, excellent. So
Yeah.
uh, so do I just press share results,
Yep, you can.
or do you? Yeah. So as you see, we had a dead tie between 20. Well, actually, not quite a dead tie. Now we did have a dead tie, and then we've got an extra one in the no camp. So I'm happy to say the no's have it, because I agree with them, which is perhaps a slightly controversial thing to say. But in my opinion, the GnRH test is a really useless test that contributes nothing to the clinical assessment of precocious puberty. And I realize that's a heretical thing to say, and those of you who are taking your boards shortly might be having palpitations. But let me explain why I think this. So let me get back to my slides. So, although the GnRH test is the classical gold standard for diagnosing central precocious puberty, actually, ultrasensitive basal luteinizing hormone and sensitive estradiol assays are just as good. I mean, what you're interested in is the axis active? And in a sense, what the GnRH test is doing is just amplifying the basal response so you can see if there is activation of the hypothalamic pituitary gonadal axis. That's all it is doing. It's not some magical test that can tell you things you can't otherwise tell from the clinical picture and the basal levels. And many children with clinically obvious central precocious puberty will already have an elevated basal LH, and this clearly makes the stimulation test redundant. What are we testing for if there's estradiol and LH on board already and the child is having physical changes of puberty and they have advanced bone age and they're tall for their age and they're emotional as a teenager? These aren't complex and difficult judgments to make. I feel that actually we should use the eyes God gave us to decide whether the child is in puberty and not rely on, in my opinion, outdated stimulation tests, which rarely contribute, in my opinion. So I'll be interested to see in either the comments or in the questions at the end whether you agree with me. So now multiple studies have been done looking at the cutoffs for basal LH or basal LH over FSH or single time point stimulated LH. And for example, we have a Thai cohort where they found that a basal LH using a sensitive assay of greater than 0.2 was confirmatory of precocious puberty. Now, if you had an LH of 0.15, that isn't therefore confirmatory, but does it exclude precocious puberty? No, it doesn't. That's what you need your eyes for and your clinical perception and the parents' input. You know, we don't need to do these tests just because we can. We need to do those tests because they add value. And I think a GnRH test rarely tells you anything that just waiting 3 months and reassessing can't also tell you. You can use a basal LH cutoff of 0.255, and this also gives a good sensitivity and specificity. An Italian study found a basal LH greater than 1.5 had 100% specificity but low sensitivity, so you would miss a few. And then you can use the stimulated LH thresholds, but I really think this is complete garbage. I mean, the stimulated LH thresholds are preposterous, to be honest. You know, this LH greater than 5 is nonsense. And LH-FSH ratios, why are we doing that? LH is enough by itself to determine whether you're in puberty or not. And I have to say that you know, it's just a cumbersome test. It's relatively costly, and it really is not adding to my clinical assessment of whether a girl is in puberty or not. There are important factors to consider if you're doing this wretched test. One of them is the time of day you're doing it. You should really do it in the morning, first thing in the morning, within 2 or 3 hours of waking. So that is impractical in some situations because LH is higher in the morning. Estradiol is higher in the morning. If the child is obese, which many children with precocious puberty are, it blunts the LH response to stimulation testing, making you more likely to pronounce that a child who is in puberty is in fact not in puberty. And, you know, as I say, use your eyes. It's not only the LH peak that matters, but the whole picture. At best, it's one part of the jigsaw. So basal LH within the normal prepubertal range is still common, even when there's clear evidence of central activation of the hypothalamic pituitary gonadal axis with clear signs of puberty. And in nearly all cases, a clearly elevated morning basal LH plus appropriate other clinical auxological findings, I think it makes stimulation testing unnecessary. And if you're in doubt, you can wait. This isn't a diagnosis you need to make today. You can actually wait and see what happens. It will declare itself. The child in puberty, you will see progressive breast development and other changes, advance in bone age disproportionate to the time that has elapsed since the last bone age. So I think, you know, we have better ways of making this diagnosis that are less troublesome to the family and to the child, and actually it is not denying us the evidence that we need for this diagnosis. So Fatima was reviewed after 4 months, and by that time she was clearly growing very rapidly with progressive breast development. Now, in fact, the family were not concerned about her height as she was so tall. And in fact, she was coping very well emotionally with the process of puberty. And based on her repeat bone age, her predicted age of menarche was greater than 10. So I have another question for you now. Should we treat her? So please answer the poll. It'll pop up in a moment. So we have around 32 responses at the moment out of 71 people. So let's see if we can get a few more responses.
People still thinking it's a challenging question.
Don't worry, there are no booby prizes. It's fine to say either answer. You want you to put your clinical opinion, what you would do, not just what you think I would say. Then you know what I would say anyway.
It's anonymous, by the way, so we don't know who's answering what. Okay, I think we need to end the poll now because plateaued response.
Okay, so we can see that 44% of you would treat Fatima and 56% of you don't think it's necessary. So let's discuss that a bit more. I'm getting yeah. So shall we move back to the slideshow now?
Yeah.
So now, in my opinion, the question you should ask is, what are we treating? Who are we treating? Are we treating precocious puberty because we can? Or are we treating because it's somehow beneficial to Fatima? So are we worried about her height? Is she going to be short? No, she isn't. She's going to be tall because she already is very tall. And even though her bone age is advanced, she will still finish with a height in the 160s. So I don't think we should be treating for her height, and that's an important consideration. Is she emotionally troubled or struggling because of precocious puberty? That would be another good reason to treat. And according to her family, according to Fatima herself, she isn't. So, it doesn't seem to be that she needs treatment from that point of view. I mean, even at the normal time, I have to say, some girls and boys struggle with the onset of puberty. It's not an easy time, but it doesn't mean that all children struggle with puberty. And if she is not struggling and she's coped so far, do we really want to put the brakes on and, burden her with a treatment that she doesn't perceive or her family doesn't perceive benefit from? And then the third reason, I think, for considering treatment would be if menarche would be unduly early. And we can see from her bone age, as I mentioned, that her menarche will be likely after the age of 10. So is that too early? Well, the family didn't think so. So decision was made not to treat. So I think we should think about what we're doing. Are we treating because we can or because we should? What are the benefits we're hoping to achieve with treatment? And I don't think there's any indication for treating puberty unless, the child is very, very young. That's perhaps a further indication. The child is only 5, then yes, we would treat. But for a girl like this who's going to have menarche after the age of 10, who's going to be a satisfactory height and who is not distressed, and her family is not distressed, and her school is not distressed by the process of puberty, then I think we should leave her alone. It would be a different matter in boys. I feel that boys with precocious puberty should be treated, and we can discuss that later if you would like. So now, one of the things you might be interested in, let me just move the slides on, is how we use bone age to determine the timing of menarche. So this is the kind of report we get from Bone Expert. This is a very accurate bone age system, and you do need an accurate bone age system if you want to predict timing of menarche, or at least a very good radiologist who's giving you very good reports that you are confident in. Now you can see in this particular example, this is actually a girl I saw in my clinic first thing this morning. You can see that her bone age was 11.78, That's 2.57 standard deviations above her chronological age. So, very advanced bone age. She's at 89% of her final height. Bone health was excellent. That's another little perk of Bone Expert. You actually get a measure of this, effectively, bone density. And that's very interesting and useful to follow when we're using bone age in children. So this is the output we get from, if we plug these data into Bone Expert, the adult height predictor of Bone Expert. So you can see I've selected European South for the ethnicity, which I think is the closest to this part of the world. And I've put in those numbers, I've put in her height, I've put in her parents' heights, and you can see that her expected height for her parents, I don't know, can you see my mouse? I don't think you can. So if you look on the right-hand side, you'll see we've got the bone age SDS, plus 2.57, as we said. APHV stands for age of peak height velocity. The adult height prediction based on the X-ray alone, only the X-ray, 157, and her current height, of course. If we look at her parents, her expected height for parents is 156.9. So it looks like she's heading pretty close to that. And indeed, when we put the two together, X plus P, the bottom right-hand box, you can see her expected height is 156.6. So it's, not bad. It's within the expected target for her parents. It's not unduly short or tall. And I want to go back now to the APHV, the age at peak height velocity, because this is actually a very good predictor of the onset of menarche. So if we look at the graph that you also get from the Bone Expert height predictor, you can see that the blue line there at 10.6 years is the expected age, more or less, of menarche. But there is a range. If you look at the lower part of that blue line, you'll see there's a sort of bracket that goes down to 10. And the upper part of that bracket goes to 11.2. So you can say with a high degree of confidence that menarche is likely to fall between 10 and 11.2. Is that a problem? That's for the family to decide. I always say to families, unless it's a very, very young child or a boy with precocious puberty, that really the decision to treat puberty is a family decision. They are the ones who know if early periods will be a problem, if the behavior or emotions are causing, chaos and mayhem at home. They are the ones who can give you their opinion about the final height. So I don't think the decision to treat is actually a medical one, assuming the child is going to be a reasonable height. I think it's a family decision, a personal decision for the family, and I always put the decision in their hands. So I've given the family the information. I've told them that periods will not start, or very unlikely to start, before the age of 10. There is a chance, crystal ball gazing does have its limitations. This is, to a certain extent, a crystal ball. We're looking at the bones to determine onset of menarche. But you can really use this information. It's a very helpful piece of information, even in girls after menarche. You can use this information. So, for example, I can then use that information to see when menarche likely was, because sometimes girls are a bit vague about when that happened, and that can be useful in predicting final height. So that was all I wanted to say about this, but I gave the decision to this family as to whether they would treat. And so mom and the girl and her dad are going to think about it and decide, and they're going to let me know. And actually, the girl herself says she is not happy that she is changing, but at the same time, she's coping well emotionally and doing well at school, and she's going to be a good height, a satisfactory height from the family's point of view. So I'm not making that decision, the family is making it. Now, let me tell you about another case that is rather more complex, but also does address this issue. So, Alia. Now, rather tragically, Alia is a profoundly disabled girl who was initially referred to endocrinology because of abnormal thyroid function, and she had central hypothyroidism secondary to anti-epileptic drugs. And these are very potent inhibitors of TSH secretion. There are some that are also inhibitors of T4 to T3 conversion, so that's another consideration. So those anti-epileptic drugs are an underappreciated cause of central hypothyroidism, and you shouldn't be afraid of using thyroxine in these children, and indeed Alia was on thyroxine. She had the most horrible seizures from a very young age, refractory to multiple anti-epileptic drugs. She had a corpus callosotomy, which is obviously pretty aggressive neurosurgery, and then later a vagal nerve stimulator. And unfortunately, she had severe ventilator-dependent lung disease, so she would come into my clinic in her wheelchair with the ventilator hissing away connected to her tracheostomy. So she really had a very, very limited quality of life. She was extremely small, so very short, because essentially she'd had multiple therapies, multiple complications, multiple infections. So all of this had impacted on her growth. Now, I was a bit taken aback when on exam I saw that she had profuse pubic hair, but there was no virilization, so no clitoral enlargement. She had dark terminal hairs on her back and arms. She had greasy hair and skin and some facial spots. But there was no breast development, so not yet precocious puberty. If we look at her labs, we can see her ACTH was slightly elevated. Cortisol was satisfactory for a 9 a.m. cortisol. DHEAS is hearty, I would say, so she's clearly got active adrenals that are making adrenal steroids. And if we look at her thyroid function, you can see the TSH was high, but the T4 was low. And the T3 was borderline. Iodine was also very low, just complicating things. So I think, again, perhaps another underappreciated aspect of the thyroid is just how prevalent iodine deficiency is, particularly in children who are dependent on hyperalimentation. So if you're on the feeds, is she getting her iodine? And she had a remarkably low iodine. And with this information, our dietitian started adding additional iodine to her feeds. So what are we dealing with? Is this premature adrenarche? I should have put another question here, shouldn't I? But let's press on. So here is her bone age, and you can see her hand is slightly deformed, sadly, from her disability. And you can see her bone age was 7.73, so plus 2.8 standard deviations, very elevated for her 5 years, 5 months age. And so this is not a happy situation. Now, in my opinion, advanced bone age and profuse pubic hair is suspicious for an adrenal disorder. So we proceeded to a comprehensive steroid panel. Here is the steroid pathway. This is to give you all nightmares. I instantly admit that I do not remember all of the steps of the adrenal steroid pathway. I have to look it up so that I know what I'm dealing with, because it is a complex pathway. But I think you basically have to think about, so my colleague Sarah Etisham, she talks about it's like driving on a 3-lane road. You have the outside lane, which is the zona glomerulosa, where your mineralocorticoids are coming from, your middle lane, which is where the glucocorticoids are coming from, and then your androgens. And if one of the lanes or one or more of the lanes is blocked, then everything gets shunted over into the androgen pathway. And you can see beyond the adrenal, there is peripheral aromatization of the ends of the androgens to estrogens as well. So let's look at some of her levels. So here we can see she's got an elevated pregnenolone and an elevated 11-deoxycorticosterone, but normal corticosterone and aldosterone. So straight away, one might think, well, is there a block at 11-beta hydroxylase? Well, we can get a second bite at the cherry by looking at the glucocorticoid pathway. So she's making a good level of cortisol, so she's not cortisol deficient, but we can see there is a backing up in the system. So she's got a high level of 11-deoxycortisol, a high level of 17-hydroxyprogesterone, and a very high level of 3-beta hydroxysteroid dehydrogenase. Now let's look at the adrenal androgens, and you can see straight away she has a high DHEAS, or DHEA rather, and androstenedione and testosterone. And that in turn feeds the estrogen. So she's making estrogen. So although there was no breast development, it's coming. And so what do we do? She's got a diagnosis. So this diagnosis, I'm sure you will see, is partial 11-beta hydroxylase deficiency. Why do I say partial? It's because she can still make enough cortisol, but the price of making enough cortisol is that she pours out an excess of androgens. So what should we do about it? What are the treatment options? Well, we could suppress the adrenal axis by giving her glucocorticoids, so that reduces the ACTH drive. We can add in mineralocorticoids, which have the same effect on her aldosterone production, so she's not having to make as much cortisol and aldosterone by herself. And we can add in a GnRH analog, and if we feel it's appropriate, we can even add an aromatase inhibitor to correct that advanced bone age. But the question is, what are we treating? Whom are we treating? What is the benefit that Alia will derive from treatment? So, are we worried that she will be short? Well, she's going to be short, and she's tiny. So will that be distressing to her? No. She is a girl with no cognitive function. Will periods occur early? Yes. Does that matter? Well, not really. She's totally dependent on carers. She's in nappies. I don't see that having periods is itself physiologically distressing and harmful. And if it was, we could do something about it if necessary. So that was my decision with Alia. I can add a postscript at the end if we have time. Now, moving on to my next case, we have Hessa. So let's look at Hessa. So Hessa presented with breast development. She had no pubic or axillary hair, no growth spurt or mood changes, but there was a history of premature thelarchy, which had resolved around the age of 3 to 4 years. And otherwise, her medical history was unremarkable. We did her bone age, which showed a bone age of 7.15 at a chronological age of 6.57, so a little bit advanced, but not drastically. And she has a good height prognosis, 163.4 plus or minus 2.6. So, and that was acceptable to the family. Remember, I'm not the one who's calling the shots here, it's the family. So we look at Hessa, and we can see she does indeed have breast development, but no axillary or pubic hair. We've got her measurements there. BMI is a little bit on the higher side, as it is so often in girls with precocious puberty. She's got a little bit of estrogen in her system. It's measurable. Her LH is active. She's making LH, but it's not super high, certainly not at a level that says this is puberty, treat me. And her FSH is, I would say, normal for a 6-year-old, possibly slightly high for a 6-year-old. Thyroid function, normal. That's very important, obviously, to do the thyroid function, because TSH, when it is high, is a gonadotrophin. And so it's important to consider, if you've got a TSH of 47, that's going to potentially tip you into precocious puberty because of its gonadotrophin effects. LH, FSH, TSH, are all very similar hormones, HCG also. So 6 months later, we see her again, and she's still at breast stage 2. Her height is proceeding as before. Estradiol has gone up a bit, LH has gone up a bit, FSH has gone up a bit. So what are we dealing with here? We're dealing with Thalange variant central precocious puberty, slowly progressive puberty, not associated with mood changes, not associated with rapid growth, and not associated with any long-term issues. She will have an earlier onset of periods, but we can see from her progress that she's going slowly. And many girls, I should say, do have this long, drawn-out phase of early puberty when things are not progressing quickly. And you don't need to rush in and treat puberty just because it's there. We can see it's coming. Her LH and FSH are not so high that I'm worried that she's going to quickly progress and that in the next 6 months before I see her again that she'll be having periods. That's clearly not the case. It's a very important diagnosis to consider because actually in this study of girls with precocious puberty, they found that 39% of cases of precocious puberty in 6 to 8-year-old girls were due to Thalange variant. The bone age is less advanced, growth is not rapid, and treatment is usually not required because they don't progress super quickly. And you can always intervene later if you feel the need. So if at 8 or 9 she's starting to progress more rapidly and parents are worried for one of the reasons we discussed, early periods, poor height, emotional issues, then yes, you can start treating then. You don't have to treat at 7. You can wait until it becomes an issue. So the important thing I would say is keep these children or these girls on the books and reassess them, and don't rush in with treatment unless it's adding value. My final case of the quartet is Charlie, who, despite her name, is a girl. So this was a girl I looked after in the UK over 25 years ago now, when I first saw her. So she was 6 when I first saw her. She was referred with early puberty and tall stature. So you can see the UK growth chart there, the old UK 90 growth chart. So she was referred with early puberty. She had always been tall, but now her growth was accelerating. And if you look at the pink dots for her height, you can see that the height is progressively diverging from the normal range. She has a very advanced bone age. This was in the sad days, the old days beyond recall when I didn't have bone experts. So we're relying now on manual bone age reading, which I always think is a bit like blind man's buff. You can have very little confidence in the report. But anyway, her bone age was 10 at 6 years, 8 months. So that is very advanced. On exam, she was in early puberty. She was tall and thin, breast stage 3, pubic hair stage 2, axillary hair stage, well, she had axillary hair, so therefore stage 2. And she had a large irregular cafe au lait patch. She had a hearty estradiol that is somewhat disproportionate to her LH. So if you look at that LH of 0.6, I'm not expecting to see an estradiol of 79 picomoles per liter. With an LH of 0.6. So this is disproportionate. So if I show you her cafe au lait patch, I think you'll all immediately recognize the diagnosis. Actually, this isn't her. This is a picture I stole from the web, but it could have been her. It certainly had a very similar cafe au lait patch. So what do we do? Well, it's a challenge because she has obviously or is likely to have gonadotrophin-independent precocious puberty. But now in those distant days when I was foolish, I decided I would do a GnRH test. And you can see that her LH was somewhat elevated at baseline and only went up to 1.8. So she would not be judged to be in puberty on a standard GnRH test, even though she is in puberty. So what does that tell us? Well, the ultrasound gives us the answer. She had significantly a significantly enlarged left ovary with multiple cysts and uterine enlargement, which was obviously a response to the estradiol exposure. So the diagnosis, gonadotrophin-independent precocious puberty, and the diagnosis of McCune-Albright back in those distant days was a clinical one. I think it still is a clinical one. I don't think you can confidently prove it with genetic testing. Even when you biopsy the cafe au lait patch and look for the mutation in GS-alpha, you don't find it quite often. My most florid case of McCune-Albright, who had terrible disease presenting at birth with neonatal Cushing's disease. I mean, she has no detectable genetic mutation, but she has the most obvious McCune-Albright picture. So don't rely on genetics to help you out with McCune-Albright. It's a post-zygotic mutation, so you're not going to find it in all cell lines. You might find it, but what difference does it make to your management, really? So now, again, this was the bad old days. So we started her on a wretched treatment, a truly awful treatment, in my opinion, which is cyproterone acetate. It's obviously basically an anti-sex steroid, so it will reduce estrogen. It also, though, is a mild glucocorticoid, so you get the disbenefit of having the bad effects of glucocorticoids and the side effects of cyproterone, which are not pleasant. So it's sort of not the best treatment. Now, if we look at what happened to her growth, if you look at the green dots, you can see that her growth rate did indeed decline. But then there's a suggestion that by the time she was getting towards 10, that her growth was accelerating again. And still at this stage in my life, being foolish, I repeated her GnRH test, and now you can see that her repeat GnRH test is declarative. She is now in central precocious puberty. So she's progressed from peripheral to central precocious puberty. And this is the problem with sex steroid exposure. If you are exposed to the steroids for long enough, they activate the hypothalamic pituitary gonadal axis, and central puberty is initiated as well. So we repeated her ultrasound and we found she had bilateral ovarian enlargement and multiple follicular cysts on both sides. So clearly she has now got central precocious puberty secondary to activation of the axis from her estrogen. So we started at this point triptorelin, and her growth slowed down. But by this time, by about 11 and a half, she'd had enough. I mean, I have to say, back in those days, triptorelin was tough treatment. We were giving it every month, so this was not, a walk in the park. So most of us will have the 3-monthly, or even as we do in Dubai, the 6-monthly triptorelin. So this is fantastic for those of us who remember the dark days. In fact, I'm old enough to remember when we had 3 weekly injections of the GnRH analogs for precocious puberty. Such is my great age. And here we can see how she progressed after we stopped treatment, and she actually did achieve a height just at the upper end of her expected height for parents. So she did pretty well, I think. I mean, she was fortunate in only having an ovarian phenotype from her McCune-Albright, sometimes, and the skin signs. Sometimes you can have really devastating and horrible problems from McCune-Albright, but fortunately that wasn't the case. But as we think about peripheral precocious puberty, don't forget environmental exposure as a trigger. So this is a story from the press published a couple of years ago, where you can see the news report, or a snip of the news report, showing that this, not actually, this is just a what do they call it? Stock photo. But anyway, a 2-year-old boy had been inadvertently absorbing testosterone from his dad's testosterone gel that he was using. And this was causing him to develop signs of puberty. And he had really a striking genital enlargement. So, transcutaneous absorption of testosterone gel is a potent initiator of puberty. But I should say that even had this child been a girl, the same thing would have happened. Puberty would have been initiated. The hypothalamus doesn't care what the sex steroid is that's stimulating it. So it would also initiate puberty in a girl as well. So even though it's testosterone, which wouldn't be good for her, she would also be making estrogen. So the learning points that I would like to say, and you may please feel free to disagree with me, I'm always happy to debate this. So treat the patient, not the disease. Treat because you should, not because you can. Thinking about ALIA, DHEAS confirms adrenal androgen production, but isn't itself diagnostic of premature adrenarche, as it's often taken to be. It's a sign your adrenals are active. So think about what's going on. Is it just adrenarche or is it something else? Be wary when the FSH and LH are not proportionate to the stage of puberty. So if you remember in Charlie, her LH was not particularly high, her FSH was not particularly high, but she had quite significantly advanced puberty, advanced bone age. So that's a sign that something else is going on. And when we're thinking about using GnRH analogs, which are good and effective and safe treatments, then it should be for good reasons. So it should be because we're worried about height, emotional or behavioral distress, or for prevention of premature menarche. And actually, I would say that in the UK, I spent a lot of my time trying to encourage families just to wait and see and not rush in with treatment. I think it's a very natural thing for parents to want to somehow preserve the childlike status of their young children. And often the natural instinct is, we must stop this. But actually, it's a process that's got to happen anyway. And if it's got to happen anyway, and they're not going to be short, and menarche is not too early, and they're not struggling with the emotions, then maybe we can leave them alone. So here are some references in which I've selected references which really support my contention that GnRH tests are a pile of useless garbage. But I'm happy to debate that with anyone who would like to. So that brings us to the end. So thank you very much.
Thank you very much,
stop sharing.
Prof. Nandu. It's amazing. Let me.
So stop share. That's it. I'm sorry. I'm a bit of a Zoom novice, I'm afraid. So I find
it's
it
okay.
a challenge.
You did amazing. So thank you very much. That was a wonderful talk, and we've learned a lot from it. Here's our QR code for the Pediatric Endocrine Cafe WhatsApp group. If you are not a member of this group, you are welcome to join us. It's a free, cozy corner for junior pediatric endocrinologists where we exchange knowledge and discuss different items related to the field. Grand. So we got a number of questions in the Q&A box. So if we take them one by one, I'll stop sharing this. So first question is from Muhammad Akram Belouche. He's got 8-year-old, 5 months, 8 years, 5 months old child having axillary hair and left breast budding. Labs done. Her FSH is 0.2 and LH is 1.2. Estradiol is 18.38, a bone age of 7 years. Does this go with a precocious puberty or not? If what to do next? Thanks. And he added that the ultrasound abdomen and pelvis are normal and her height and weight are normal.
Okay. So two things. So one is that technically it's not precocious puberty because she's above 8 years of age, and therefore we would say early puberty. So it is early, and that may be a problem for the family and the child, but it's not necessarily a problem. And yes, she's in puberty. You've got the clear evidence, you can see it with your eyes. She's making estrogen. She's got physical signs of puberty. She's got the bone age and other features. But the ultrasound often is reported, especially if it's not done by a really experienced radiologist, and you're just getting, oh, the ultrasound is showing a prepubertal uterus and ovaries. I've seen that so many times. But if you get a quality ultrasound then that you can trust, then you can rely on the ultrasound. But basically, in early puberty, don't expect to see major changes in the uterus or ovaries. You might see follicular cysts if the radiologist isn't blind, but it's not a given. And in terms of treatment, my views on treatment. Treat if you need to, based on the family's guidance as to what they feel is a priority for her.
Vian Sadiq is asking, do early and prolonged exposure to microwaves from mobile phones and internet cause precocious puberty? I presume this is related to the electromagnetic fields, perhaps. And so the question is, the exposure to this kind of environment causing precocious puberty through changing the release of pituitary hormones?
To be honest, I have not seen any compelling evidence to support this. I think it's one of those things that's out there on the wild world web rather than, in the scientific literature. I think people make these claims. I mean, if we're talking about microwaves, then not microwave ovens, I should say. They have a Faraday cage, so you're not getting microwaved standing next to your microwave. But microwaves are emitted by radio transmission equipment. If you're standing next to a radar, that will certainly give you some microwaves. I've not seen compelling evidence of this. What we do know is that puberty is getting earlier and earlier in girls in particular, and in boys actually. I would say that the most compelling evidence about what is driving that is probably obesity. And there may be environmental factors. People talk about BPA exposure, from plastic bottles or whatever. And that, is plausible that there could be that relationship, but there is no proof of this. And, similar concerns have been raised about sperm counts, for example, in boys being diminished by these environmental estrogens and other environmental chemicals. Environmental chemicals can induce things like breast development in boys. I've seen that. When boys have been, if you have, and in girls actually, but it's obviously harder to differentiate it in boys. But if you're using bubble bath and it's got flower oils in it, like lavender, then that has naturally occurring plant estrogens, and that has been shown to be associated with precocious or, well, breast development essentially in boys, so gynecomastia in an otherwise prepubertal boy.
Thank you. Now, Amina Sheikh is asking, is the LH cutoff same applying for both sex? For males and females?
It would, but I think the important thing is really to get away from cutoffs. I mean, that's partly what I was saying is that, look at the patient rather than look at some absolute cutoff. It makes no sense to me that 0.2 defines puberty, but 0.19 doesn't. So if the clinical picture is hollering at you, this child is in puberty, they're in puberty. The fact that the LH doesn't quite align with your hopes doesn't make it untrue as a statement. We know that LH and FSH for that matter, and estradiol are quite volatile, particularly in early puberty. Maybe you caught them at the wrong time of day. Maybe you caught them on a day when the LH was lower, and had you done it the day before or the day after, it would have been higher. You don't know this. We don't have a transcutaneous LH sensor to detect these things. Although you can do in some labs, in the UK, we did have urinary gonadotrophins that you could measure on a first morning urine sample, and that's actually a pretty good test if you can get it. I've never been able to get access to it here in UAE.
While we're
And
talking
that
about
obviously is easy to repeat.
talking about that, so you referred during your talk that you were lucky that at your lab you have LH assay that is sensitive, so basal LH is sufficient. So how can we ensure that our labs also have a sensitive assays?
Well, to be honest, I think it's just a matter of asking for it, for pressing for it, for saying why you need it and what you can do. If you have this test that you don't have to do, I mean, it may be your hospital would thank you for not doing GnRH tests. It's tying up nurses' time, it's unpleasant for patients, it leads to quibbling with insurance to the most infinite extent. So I think, ask for it and maybe you will get it. It's an available test. It's, can be done. So in UAE, we have the National Reference Laboratory, which is actually essentially an affiliate of LabCorp, which is a big American corporation. So we have full access to the LabCorp catalog of tests if we need it. Via our lab, they contact NRL, and NRL arrange it. Either it's done locally in country, which increasingly is the case, or it's shipped to the US. And in terms of what if we can't get it and it's just not available in our country, then you can wait. You're not in a rush to diagnose precocious puberty. It's not an urgent diagnosis that you must make today or tomorrow. It's a test that can be repeated. So you can look at the LH over time and see what's happening to it. So and if you're seeing that it's, flickering into life, or the girl is progressing, or the bone age is advancing, or she's clearly in puberty from other clinical signs like, hectic emotions and so on, then, what is it telling you that you don't already know?
Okay. Vian is asking again, what is the extent of effect of non-healthy lifestyle which disturbs the sleep and non-healthy diet on the hormonal secretions of the body and then on puberty?
Well, I think probably the unhealthy lifestyle is one of the factors that is associated with obesity. So I don't think it's a direct link that, puberty is puberty. It happens when it's going to happen and it's different in different people. But I think what we do know is that obesity is definitely a driver of puberty. And essentially, it seems that early accumulation of body fat is leading to aromatization. So then your adrenal becomes active. So then you start aromatizing your adrenal androgens, and estradiol is very potent at advancing bone age. And so I think, and that will in due course lead to, the full manifestations of puberty. And is it too early? Well, it depends.
Okay. Lots of thanking messages. Amr Mercy is thanking you for sharing your knowledge and wisdom. Fatma
Thank you,
Uthman,
Emma.
Fatma Uthman asking, how can we approach a 5-year-old with adult smell sweat? So it sounds like a premature adrenarche.
Yes, so I agree with you. That's most likely to be premature adrenarche. So a girl like this, you can. So there's evidence from studies done in Spain um, um, that you can treat premature adrenarche with, it's nearly always in a very young child like this, assuming there isn't some adrenal disorder like non-classical CAH, it's nearly always associated with obesity. And so there's good data on the use of glucophage or metformin, particularly if you can get it as a medicine, and that can be combined with anti-androgens. Now, the one that they initially used in studies was flutamide, but that's really no longer used because of liver failure, and no one deserves liver failure as a consequence of premature adrenarche. So what I do occasionally use, although not in adrenarche usually, is bicalutamide, which is the new flutamide on the block, and it's not associated with liver failure. I wouldn't
Okay.
feel it was necessary to treat adrenarche 9 times in 10 you can leave them alone. I just normally advise anti-perspirant deodorant so that the child isn't embarrassed by this at school, and then and regular showering, of course. And then monitoring the bone age, because when there's premature adrenarche, puberty will come early. And so I would probably repeat the bone age in 6 months or a year's time, depending on how they were doing and what stage
Here's
they were
an,
at.
here is another question that stimulating some kind of discussion. Asma Mustafa is saying some endocrinologists use decapeptyl with growth hormone therapy. And the reason for using growth hormone, she's explaining, in causing advancement of bone age. What is your opinion about benefit of GnRH analog with growth hormone after 11 years?
So I think it partly depends. I could have put a case of exactly this situation actually in my talk today, and I didn't. I refrained because it sort of opens a whole new can of worms. My personal preference, if I'm worried about height, if I'm seeing a girl who's going to be very, very short, let's say I'm seeing a 9-year-old, she's had unexpectedly early menarche, parents were blind for the 2 years beforehand and didn't notice she was getting breasts. And now they're terrified she's going to be, 143 centimeters. So what can we do? And I would use the 6-monthly triptorelin because we have it here in UAE. But I would use anastrozole in combination with that as my first preferred therapy. It was a beautiful, small, albeit randomized controlled trial from Greece, which showed that 2 years treatment with GnRH analog and anastrozole adds 7.5 centimeters to final height. If you just use the GnRH analog alone, it's about 1.9 centimeters. So yes, if you're in that situation and you didn't have an anastrozole or didn't want to use it, or the parents didn't want to use it, then you could use growth hormone. But the problem with growth hormone, it's tough therapy. Once you start growth hormone, if it's working, if it's doing anything, then you're really committed to continuing that till the end of growth. So, this girl of 9, you're saying, well, okay, you've got to have 4 years of daily growth hormone injections. Is that what the family wants? Is it what they really want? What people want to do is they want to be, for the girl not to be in puberty and then for them to forget about things, when the growth potential has been restored. And I think anastrozole is magic for that. It works wonderfully well in combination with GnRH analog. So that's what I would do. And I have a very nice case that I presented at the Emirates Pediatric Endocrine Conference 2 or 3 years back, where actually I had a girl that I did the full Monty. I started her on triptorelin and anastrozole, and then because her growth started to falter, we added growth hormone. And actually that combination took this girl who was looking at a height of 147 centimeters, took it to her final height of 158 centimeters. So despite having had menarche at a young age, she managed to achieve a very good adult height. So yes, growth hormone has a role, but it's a tough treatment. You have to keep going with it until you're within spitting distance of final height, or you lose the benefit. Growth hormone is not something you can stop before time. If you stop it before time, you get catch down growth and you lose a lot of the benefit. And I often see this particularly in boys, actually, pubertal boys who stop their growth hormone prematurely. And they were on track, they were on the 75th percentile, growing beautifully. You tell them confidently, yes, you're going to be 181 centimeters and it's looking great. And then they stop taking it. And lo and behold, their bone age advances tremendously and they finish growing and they're 173 centimeters. And you think, well, that 8 centimeters they've lost, that was equivalent to the entire period of time they were on growth hormone. They've really undermined the efficacy of treatment by doing that.
Providing and given that they are not growth hormone deficient, what dose do you start them on?
Personally, when I'm using growth hormone, even in non-growth hormone deficient indications, I usually start on a physiological dose of growth hormone and then titrate according to response, because some children will respond beautifully even at a growth hormone deficient dose. And the dose I personally prefer to dose by surface area, which obviously takes account of obesity, which is relevant in this group. So I dose 1 milligram per square meter, but I guess it's broadly equivalent to 35 mics per kilogram per day. So I think you pays your money, you takes your choice about which you do. But if I saw a child wasn't responding as expected, even if they had growth hormone deficiency, I would increase the dose of growth hormone. I'm not going to give up on them because they haven't responded as well as I'd like. We talk about it here and so on, but assuming they're taking it, then a higher dose can help them.
I know that our time is up now, and I know that you came back from work immediately to this webinar. So thank you very much for your time, your efforts. But we still have a number of questions. So are we okay to take a couple of more questions, or shall we end up?
Well, I'm very happy to answer
You're
the
happy with that?
questions.
Okay.
Please give me the questions.
Okay. So Farah Samir, thanking you very much, Prof. Nandu. Her question is, how do you decide which and how do you decide which GnRH analog, example, triptorelin or leuprolide or hysterolin implant to use at your center?
Well, I guess that's simple in that we don't have histrelin in UAE. So if we had histrelin, well, I mean, in the US, it's phenomenally expensive. It's something like $45,000, for the histrelin implant. Plus, you have a medical procedure to implant it. So, but on the other hand, it will last for at least a year and probably closer to 2 years. So if you had histrelin, well, it's a good option if you think you're going to be treating for a while. Often, in fact, all you're trying to do is delay things for a year or so just to get them to a better age of menarche or better height, so you can buy a bit of time with, the GnRH analog and anastrozole. Now, I personally prefer triptorelin because it's not associated to the same extent with adverse weight gain as leuprorelin. So with leuprorelin, leuprolide, same thing, then you can see quite significant adverse weight gain. I think fundamentally, unfortunately, just because you've taken away the puberty doesn't mean you've taken away the appetite that was associated with puberty beforehand. So, but for whatever reason, the evidence is, and there is published evidence on this, that triptorelin is better, not associated with adverse weight gain. I've not yet met the girl who's satisfied that their weight is now perfect. Even the skinny ones don't think it's perfect. So I think, if you can avoid excess weight gain, that's probably a good thing.
And her second question is, how would you monitor the efficacy of GnRH analog therapy? Is it by clinical or biochemical or imaging parameters?
So all of those. So I would, so when the girl comes for her next 6 monthly shot of triptorelin, I would be asking the parents, or if they were on a 3 monthly, I'm seeing them in 3 months' time, I would ask if the child's getting breakthrough symptoms suggestive of hormonal breakthrough. Now, going back to the dim and distant days when I was a fellow in Manchester, sunny Manchester in the UK, where it never rains, it's almost like Dubai, actually. Then we would be tortured to do GnRH tests on our children coming back for their repeat GnRH injections or GnRH analog injections so that we could see whether they were adequately suppressed. And I can tell you, I quickly came to realize that it told me nothing that my eyes and brain didn't already know, which is the child is having symptoms, they are having breakthrough, or the child is not having symptoms and they are not having breakthrough. And that was the clear-cut thing I would say. So you can actually be guided by the parent's impression of whether the girl is controlled or not in her puberty. And I think that's very reliable. But obviously, I also, I love my bone age. So I would repeat the bone age as well. So not 3 monthly usually, after 6 months. And I would see, if in 6 months, even though they've had the 6 month injection, which is technically it's actually a 24-week injection, but anyway, never mind. So after 6 months, if we see the bone age is advanced by 8 or 9 months in 6 months, then that's a sign that they're clearly getting hormonal breakthrough if I didn't know from what the parents had already told me. And in that situation, I might well. So there are two options basically. One is to increase the frequency of the injection, so you're giving the injection after 5 months maybe, or you add an anastrozole, which is an excellent treatment in girls, provided that, obviously if the girl is going to be, 182 centimeters anyway, you may not want to add extra centimeters to her height. But if it means that you don't need to go in with an expensive extra early shot, then that's a good way of managing it.
Nandu Abati is asking, which is more sensitive for diagnosis of precocious puberty? Is it the LH or estradiol?
Well, LH, I would say, but estradiol is also very helpful to me. If I'm seeing that there's a hearty level of estradiol, LH and FSH and estradiol are all volatile, but estradiol has a longer half-life, so it hangs around for longer. And you ask the patient to come in the morning. Oh, yes, doctor, I came in the morning. And then you look at the lab and it was midday, and you think, oh, God. So, sometimes, things aren't quite as you are told or as you expect. And I think estradiol is valuable in that sense, particularly, obviously, compared with the LH. And I do use FSH. And I encourage, our fellows in Al Jalila when I was there to look at the LH and FSH, but I don't believe in ratios. Ratios are hot garbage. Another piece of endocrine dogma that should be tossed into the skip of nonsense to be not adhered to. So honestly, the evidence for ratios is flimsy at best.
Okay, thank you. So Sundus is asking, if we have a patient with precocious puberty but with delayed bone age or short stature, how to manage? Do we need to consider addition of growth hormone or not to treat? That made me thinking of Van
So
Wicke-Grombach.
Well, yes, if they're short with precocious puberty, then you have to look more seriously for pathology. Now, normally, I recommend, I didn't talk about it today, but I do recommend an MRI in girls with precocious puberty, but I put it to the parents, there is a small chance there could be a significant underlying cause. In my experience, most parents don't want the MRI. And to be honest, that's fine with me. I'm not worried about it. We can always revisit that, if there's a concern that actually she has a brain tumor or, the prolactin is sky high or whatever, then yeah, we do the MRI, don't we? But I think, if you're in that unusual situation where I would say you've got incongruous results that are not matching, then you've got to look harder. So maybe the advanced bone age, sorry, was it delayed bone? Yeah, delayed bone age and precocious puberty. Well, then, yeah, as you said, the Van Wyck-Grumbach, the hypothyroid, stimulation for the TSH stimulation of the gonads could be going on. Now, this is a factor in boys as well. They don't have early puberty, but they get testicular enlargement under the influence of TSH. And interestingly, the pituitary itself enlarges significantly with TSH, as well as the gonadotrophins, by the way. So I explain it to our fellows, that, in childhood, when you're not in puberty, 80% of the pituitary's job is growth, and that's what it's doing. It's 80% of the pituitary is dedicated to growth hormone. But once you're in puberty, then more of that function of the pituitary is making gonadotrophin, so the pituitary has to enlarge. So in puberty, we see pituitary enlargement relatively, and if you have hypothyroidism, you also see pituitary enlargement as a potent cause of that. So as well as the enlarged testes in boys and precocious puberty in girls, a clue to the hypothyroidism is if you see premature menarche that's disproportionate to the stage. When you're seeing menarche, you think, well, that should be happening, at the end of puberty, not at the very beginning when there's barely B2. So if you're seeing that, then think hypothyroidism. But you can also see the condition of idiopathic premature menarche when, and this does happen early in puberty. They seem to have something that resembles a sort of micro period, lasting just a couple of days. Maybe it goes on for 2 or 3 months and then peters out. So that idiopathic premature menarche basically is a consequence of enhanced sensitivity to circulating estrogen, which is the same thing actually that you see in premature thelarche. They're basically just more sensitive to the estradiol that's going around. So you can therefore see more consequences of it.
Okay, and you partly answered, perhaps you answered Mariam Benturki's question about MRI. So you would do it if things are not matching or not going with just simple precocious puberty. Then Selwa Mahmoud is asking, when would you stop the treatment for central precocious puberty, the generational logs? Is that dependent on patient height, patient age, or bone age, or all of them?
I guess all of them, but to be honest, it's often the girl telling me that she's not having any more injections. So I think by the time the girl is asserting herself to that degree, probably the time has come, to stop. And typically, I would say between 10 and 11 years, most girls have had enough by then. I do have the opposite. So I have had some cases where girls have wanted to continue treatment because they're worried about puberty or afraid of puberty. And then we have to approach that. Well, look, even though you want to continue, now you're 11 and a half, I really think we should let things happen because, it's a journey you've got to make. And therefore, now that you're this age, 80, 90% of your friends at school will be in puberty. So you don't want to be very different from that. And one of the things I explain to parents, because they are understanding of this concept, is I say, a girl of 9 is very different psychologically from a girl of 13, also a boy of 9 and a boy of 13 for that matter. And, this is the journey your brain has to make as well. It's not only about the physical manifestations, you have that emotional maturation and progress. And one, just a minor aside, I'm not bothered if on triptorelin we're seeing a little bit of hormonal breakthrough each time. It doesn't trouble me, that there's a little bit of hormonal breakthrough, a little bit of progression of breast development. Is that a bad thing? I don't think so. I think that's actually good and in some ways reassuring to parents that actually when we stop the injections, things will just carry on beneficially. But if it's a problem, it's a very young child or the emotions are just awful for the family, then yes, I would hit them with an anastrozole to calm down the estrogen. I prefer
Fantastic.
anastrozole to letrozole, but just because I think it's better. But
Last question from Huda Yassin. She thanked you initially, lots of thanking messages from Huda, Osama, and other colleagues. Then she asked, would you do GNR stimulation test to raise estradiol if mass spectrometry is not available?
uh, do you know, in the last 20 years, I've probably done 5 GnRH tests, something like that. I mean, it's a test I almost never do because, um, it's not something I feel is terribly helpful. Even going back to Charlie, our girl who progressed from peripheral precocious puberty to central, I think it didn't really tell me anything I couldn't have inferred from baseline gonadotrophins if you looked at the basal level of LH and FSH in those tests.
Okay. So I hope that message is clear.
So the
So
short answer is almost over my dead body would I do that test unless I had a good reason for doing it.
yeah.
There was a question,
Well,
I think, from Mariam there, Dr. Mariam.
Maria, I think her question was about MRI,
I
unless
saw a
there's
hand
another
go
question.
up. So,
Ah, sorry, I don't see the hand. Now I've got a question from Isra Majid. Isra Majid is asking,
okay.
I've seen many patients with cerebral palsy on anti-epileptic drugs have features of premature adrenarche. Is there any relation?
Um, Yes and no. I mean, there is dysregulation of the hypothalamus in epilepsy and cerebral palsy and with the anti-epileptic drugs. And this is what underlies the central hypothyroidism that we often see, particularly with some of the newer drugs like levetiracetam or oxcarbazepine that the brainologists all love. So I'm sure that it is having an influence, and I agree that I do see adrenarche. So, in going back to Alia, my initial thought was, could this be adrenarche? But it didn't fit really. It was more pubic hair than I would expect just from adrenarche. So I think use your eyes and your wits and think about the case, and I think that will help you more than tests will help you. But in on the whole, tests are needed, but I try to be minimalist in my tests. When I do the tests, I'm greedy, but I do a lot of tests, but I generally try to avoid doing them and manage with bone age and clinical observation. I think
Very,
there was a
very last
question about.
question. Very last
Okay.
question from Amani.
I think I I think
Why
Hussein is tired now.
why do you do GNRH test for peripheral precocious puberty?
Well, the reason would be, of course, as you know from what I've said, I wouldn't do it nowadays, but the reason would be because you don't know at the point in time when you're seeing the child whether the puberty is peripheral or central. Just because they have a birthmark doesn't automatically mean it must be peripheral precocious puberty from McCune Albright. It could be, peripheral precocious puberty from an ovarian tumor or, from some other reason. The flower oil exposure from the bubble bath, whatever is causing it, you don't know at the time you're doing it. So then the GnRH test does potentially discriminate the two, but you'll know from what I've said that I think it's a poor test that adds little for most patients.
At the end of the session, I would like to thank you sincerely for your time, for your efforts, for being with us, for sharing your knowledge and wisdom. Thank you uh, uh, very, very much. And I hope that we could host you again for another session if your time
Yes,
allows.
please, I'd be pleased to join you all again.
Have a good night. Thank you very much. And thank you very much to our audience. And I wish we continue together to grow together. So your feedback is important to us. And if you can either drop us your feedback here in the chat box or in the Endocrine Cafe WhatsApp group, we'll appreciate that. Thank you very much. And bye-bye.
Thank you.